Hello, welcome to this presentation by FERNE, the Foundation for the Education and Research in Neurological Emergencies. This educational lecture is titled The Evaluation of Emergency Department Dizziness Patients, New Concepts. My name is Edward Sloan. I am currently Medical Director of the Physician Assistant Studies Program at Dominican University. I have most recently been an attending physician at Carle Foundation Hospital, and I am Professor Emeritus in the Department of Emergency Medicine at the University of Illinois at Chicago. Support for the development of this lecture was provided by EB Medicine. I am currently President and Board Chair of FERNE. The content for this lecture comes in large part by the monograph titled The Timing and Triggers Approach to the Patient with Acute Dizziness by Jonathan Edlow. It was published in Emergency Medicine Practice by EB Medicine, December 2019. Other parts of this educational lecture and the complete lecture are available at the fern.org website or on our YouTube fern.org channel. Also available is the June 2020 podcast, which was presented to participants in 46 countries, as well as a CME option on the EB Medicine website at ebmedicine.net, as well as at the specific website address noted below. Please note the disclaimer listed below. In general, this information is intended to augment and not replace the clinical judgment that guides the management of any individual patient. Let's talk about dizzy patient conclusions. There's been a lot of information provided you today. I'd like to thank Dr. Edlow for making it clear as to how we should address dizzy patients. First, acute, severe, continuous symptom patients who present to the emergency department. That is an acute vestibular syndrome. That is your first diagnosis in your list of diagnosis in your electronic medical record. If the symptoms are not continuous but are intermittent, then considered a triggered or spontaneous etiology. Next, if you have orthostasis or BPV or posterior stroke, these are the three diagnoses that top our list that we must consider. Orthostasis being a systemic problem due to volume depletion. BPPV, which is a peripheral problem, which most often is triggered and is triggered often lying in bed. Or posterior stroke, which is suggested when any of the 5 hints tests suggest a possible posterior stroke etiology. So you must have those 5 exam findings to help exclude posterior stroke in this system that's been developed by Dr. Edlow. Remember that the BPPV diagnosis is confirmed with Dix-Hallpike and be treated with epi, and that epi may need to happen several times with an ENT specialist because it's like physical therapy. Remember, you have to have caution in the setting of COVID-19 pandemic. As my daughter, who's a physician assistant in the emergency department, said recently, you must be very careful and consider COVID-19 as a possible cofactor or covariable in the cause of many symptoms, including neurological symptoms. And lastly, I think you can use EMR templates based on this information and dot phrases that help you make the exam process systematic and easily accomplished, and the history process for that matter. So my recommendations. Remember that dizziness pathologies fall into 3 diagnostic strategies with 6 diagnoses, and this fall into 3 general treatment categories. That's why I put it in parentheses on the slide. You must study the Nystagmus findings and symptoms and BP maneuvers online and in the monograph. And remember, you have to consider nystagmus in the setting of either acute vestibular symptoms where all the bad nystagmus findings are of concern, or you consider nystagmus in the setting of likely BPPV, in which case you can have things such as rotatory or vertical or direction changing nystagmus that occur with this benign peripheral etiology. I recommend you make templates, dot phrases to exclude posterior stroke findings in your dizzy patients. And I think it's important to explain the diagnoses to the patient and provide them adequate follow-up and give them some expectation, knowing that dizziness can takes several days to recur if it's an acute vestibular syndrome, and describe to them what is important if they have intermittent, whether it's non-triggered episodic or triggered intermittent vestibular syndrome. And I think you have to have particular caution in dizzy patients with the COVID-19 pandemic ongoing. So for questions, I would refer you to ferne.org@gmail.com or the ferne.org website. This information, including PDFs of this slide set, are available. I would recommend that you look at the monograph and contact EB Medicine if you have an interest in looking at more of their monographs, which are an excellent source of clinical material as we practice emergency medicine in the emergency department. My name's Ed Sloan. I want to thank you for the time you spent with us today, and I encourage you to look at all of the different segments of this podcast and or to listen to additional podcasts, including one on life-threatening headaches and the COVID-19 pandemic, and other podcasts which will be provided to you in the future. Once again, thank you.